Hi everyone. We're on, Paul. Can you all hear me? Fantastic. First, let me apologize for my unusually croaky voice. I'm on the back end of a flu that I'm sure all of you know someone who's gone through. This flu season's been particularly horrid. Well done to Nedbank on picking the day. It's like when you pick good weather. I mean, this is it's like the kind of thing where you sort of thinking, what am I going to speak about? And you start your preparations long ahead of time, and then as like this impending idea of the signing of the NHI bill just the day before, like, should I change what I'm going to talk about entirely? Like, it's such a big sort of moment. I prepared some slides really just for props for myself to talk through some of the topics that I'm going to chat about today. And I'm going to try and get through them quickly, really just to set the scene a little bit top down. I always like the actuaries like to take a sort of 3,000 feet view of things. And we like to look at the past and think about the future and all of those kind of things. So I'm going to do a very quick run through some of those things. I'll tell you my views. I'll answer any questions you might have about what I think is going to happen, and I'm sure the panelists will have lots of views to express as well. But let me start with this, one of my favorite visualizations. It's a little faint, and some of you may be far away, but I'll try and point out what I want to show you. This is called the Lorenz curve that compares GDP and life expectancy. The stated aim of our health, if you look at the byline of the Department of Health, it says a long and healthy life for all South Africans. So that's really what you want your country to do, your health system to do. It give you a long and healthy life. And so we know that as countries are wealthier, their life expectancy tends to go up, and we can watch how this develops over time. South Africa is the little red dot, if you're watching on your screen, and it's got a tracer on it, so you can sort of see how we're developing. And as your GDP improves, so does the life expectancy. You can put more money into healthcare. You can more beds, more doctors, etc. Unfortunately, in around the 90s, HIV became a global crisis, and South Africa was a standout, spectacular fail from a policy point of view in terms of how it handled HIV. And so we lost about 10 years of our life expectancy during that period because of bad policy. I'm sure you all remember. Fortunately, we then got ourselves on track with the ARV program and have regained most of that lost life expectancy. And you can see we sort of, back up into the 60s. And then COVID set us back again, like it did much of the rest of the world, in terms of lives lost. Although again, so not really for lack of trying, the effort was spectacular, but we still had a very bad death toll for COVID, but in international terms. Now I just want to so this is how the curve would look typically. So you would see that this flattening out at the top is normally where, once you reach a certain point of life expectancy, until we get some kind of genetic breakthroughs, we're pretty much, living till like high 80s, low 90s. Japan is right up there. I've trimmed out some of the outliers. But at that point, if you're putting more money in healthcare, it's really just for luxury, like nice technology, more comfortable hospital beds, those kind of things. So there's a diminishing return, if you like, in terms of investing. But, near the bottom here, there's still big gains to make on the life expectancy by spending more on healthcare. And you can see South Africa, unfortunately, is off the curve with some other countries. Now, there's some reason for that if we think about our two-tier system. And when I say our two-tier system, I really mean our economy as a whole, not just the healthcare system, because our healthcare system, as inequitous as it is, unfortunately reflects our economy. We have a have and have-nots economy, which I'm going to talk about a little bit. Education is the same. Transport is the same. Food is the same. Transport is the same. Living conditions are the same. To think that we can find one part of our economy that is exactly the same across all income sectors is just a fantasy. And so healthcare reflects that, and we have to bear that in mind. Just to touch on HIV, so we like to talk about South Africa having the biggest HIV program in the world. Well done to us. The way I like to talk about it is it's something we should be simultaneously proud to have achieved, but ashamed to need. We shouldn't have needed that. And the reason we have such a wonderful, massive HIV program is because we screwed up HIV policy for 10 years. Shouldn't have needed that. So we would have been about here. We would have been much closer to the curve if we had a much more progressive HIV policy early on, but we didn't. So we're still where we are. But then if we had to split out the haves and haves not, if I think about actuaries get involved in life insurance, and if I think about the kind of life expectancy that an affluent person would be priced for in a life insurance, if everybody in this if you go and had to sign up for life insurance through a fully underwritten process, the life expectancy, assuming you're non-smokers and assuming like that there's no underlying chronic conditions, they're going to assume that you're living into the high 70s, early 80s, like mid 80s. That's the affluent life expectancy in South Africa. But now the only way that can be true is if it's balanced out by life expectancy of the poor, which of course is much more heavily affected by that HIV burden. And so this, if you have to try to understand from an actuarial point of view why we're off the curve, it's because we're actually on the curve, but two separate sort of subparts of our economy. So in healthcare, sort of we've walked this long journey of reform. Predates many of our careers in healthcare. There used to be friendly societies and then various versions of the Medical Schemes Act. This is a whole slide presentation on its own. More recently, sort of in the current dispensation of the Medical Schemes Act we have right now, which was promulgated in 1998, we have been waiting for that reform cycle to finish. We have been living under an imbalanced regulatory environment in the medical schemes world since 2000, and was then significantly distracted in 2007 when we took this detour towards NHI. So there was a very clear, very well-researched reform pathway that was planned for healthcare in South Africa up until 2007, and then there was this detour to NHI. The private sector has largely been ignored from a regulatory reform point of view up until that point. And so this is very important when the critics of the private health system say, it's unsustainable and it's unaffordable and look at the escalations. A large reason for that is because of the regulatory reform we've been clamoring for the last 15, 16, 17 years is just not there because the focus has been on NHI and quite slowly at that. Many reforms that needed to be completed for the medical aid sector to be more sustainable. We could have anywhere from 15 to 25% lower contributions in the medical aid world if the reforms had been seen through, but they haven't. And so it's a little bit sort of, pot calling the kettle black to say, well, this is, unsustainable or it's so expensive. Well, it's expensive because of PMBs. That's a regulatory phenomenon. It's not a market phenomenon. Now, you can't say, well, you haven't been able to grow because it's unaffordable because the floor price is set by regulations. So, there needs to be a lot more regulatory completion in the health sector for that to be solved. But in the meanwhile, and I'll touch on this, there's so much of innovation bubbling under the carpet. So we've abandoned the necessary regulatory reforms to complete what would make medical schemes more sustainable. From a regulatory point of view, there's still lots of innovation keeping things going, and of course, there's been stop-start regulation on the so-called health insurance environment, low-cost benefit options, which started all the way back in 2006, and still we have nothing to show for it. Although now there is this market, which if you're interested in that, we can talk about a little bit. And now we have a pen. So now it's signed, and the green paper so long ago, 2007. And white papers and all of the various discussions and most of the engagement with sectors ignored, etc. And now it's signed. And I was saying to some of you out in the foyer, it feels a little bit like, some of you may have had friends or family that go through this process where there's some unknown medical malady that they can't get to grips with, and they've gone for this test and that test, and they're sort of feeling unwell, but they don't know what the problem is. And then eventually they come to a diagnosis. And even if it's a bad diagnosis, there's some kind of sense of relief. Okay, now I know what it is. Now we've got something to sort of push up against, to fight, to treat, etc. And I must say, at the BHF conference last week, that's what the sense was in the room. Like everybody's energy was up. There was with all this uncertainty, but actually we're just ready to fight now. Like we've been arguing and we've been trying to get on the same page and talk nice to each other and all that kind of thing. But if we're going to fight, then let's fight. And we'll go to the courts and we'll sort of, the learned judges with all of the expert testimony can help us decide who's right and who's wrong here, because we're not coming to agreement. And that's what it feels like in the sector at the moment. Before we talk about NHI, I also want to defend that sector a little bit, that medical sector, because so often the criticism is it's unsustainable, it's unaffordable, it's all these kind of things, it's stagnant, it hasn't grown. Well, I want to put to you that actually the medical sector is remarkably resilient given the economic environment that it's operating in. The reality is it's out-of-pocket spend. whether it's employer subsidized or you paying yourself, it doesn't matter. It's out-of-pocket spend, which means you need to be earning a salary. And you need to be earning a meaningful salary at that because it's not cheap. Now, how can you say that the market is stagnant when there's no more jobs? In 20 years, we've not meaningfully created more jobs at a nominal level. The number of assessed taxpayers, which, what is that? This year's like the tax threshold is like 80,000. I mean, that number hasn't moved in 20 years. And so how are we going to say that we would have expected what? How many we would expect these medical aid members to come from if there's not more taxpayers? They can't come out the ether. Okay. So when we say the medical aid sector is stagnant or the membership is stagnant, what we're really saying is the country hasn't managed to create more meaningful jobs. It's a macroeconomic problem. It's not a sectoral problem. In fact, it's remarkably resilient. The population has increased 18% over the period. Personal income tax payers, pardon my spelling, has decreased by 3%. Scheme beneficiaries have increased by 4%. So we've done remarkably well over the period, actually. That said, we know that affordability pressure is very high. We saw it during COVID. I mean, even during COVID, people held onto their medical scheme coverage. There was a dip, but remarkably sticky. But affordability pressure is very high. We can see it in the kind of plans that people are choosing. We see data on about half the medical aid industry, and we can see just from the way that people are choosing their plans, we can see the kind of way that the claim patterns are emerging. There's enormous affordability pressure. So, I mean, the game is on for the industry to innovate, to reinvent itself, to look for those lower cost solutions. A lot of our advice to clients, they're asking us all the time, help us develop a new low-cost option. How can we structure these things? How can we contract more selectively? How can we get better prices? How can we, and all the while trying not to just transfer the burden onto the member by making, trimming benefits and cutting benefits. But we see that the pressure is there. It's very evident. All the while, there is this, and more evidence for that cost pressure is this bubbling health insurance market. We think there are probably at least 1 million policyholders on these so-called primary health insurance products, where they are exempt from the Medical Schemes Act. They were really started by sort of not the big insurers, the sort of cottage industry insurers nobody really heard much about, and were prepared to take some regulatory risk and put product out in the market. They sort of evolved out of employer health funding arrangements and EAP programs, and now they offer meaningful primary care benefits. You can buy products for 250 Rand, 450 Rand, sometimes more, and they offer you like GP visits, pathology tests, etc., but not the full benefits of a medical aid. We just signed a client now where the majority of the workforce is on these, are lower income earners, and they're on these insurance products because they want to give their employees something. They don't want to leave them at the behest of the state because they know if they get like one sick leave day turns into a week. Now they've got a product where there's easier access to private primary care, and the products are meaningful, but at risk of not being regulated properly. And so that's another area of regulatory frustration. Just let the market do something here. And then lastly, I mean, just to tie up this theme before we get into NHI, I like to ask this question: what do we think what would be the one thing that would improve the health of South Africans? Is it eating better? Is it exercise? It's not that. We need to create more jobs. It's that simple. We could create more jobs, and I'm going to touch on this in one more later slide. More jobs mean more money in the fiscus, more people able to afford cover for themselves in a medical aid or health insurance paradigm, more tax, a better funded public health system. It would, plus, I mean, you look at the numbers in South Africa, at a macroeconomic level, things are much more frightening than the NHI bill. If you do the maths now, 50% of our population are living on 50 Rand a day or less. I mean, this is a very important thing to sink in. I do another talk on social determinants of health, where I talk about, what this means and how can we expect our population. We have about a 26% obesity rate in South Africa. How do you expect people to eat nutritiously on 50 Rand a day or less? I mean, just think about what that means. We have very, very big macroeconomic problems to solve. Okay, NHI, here we are. We've signed. Now what? First thing is don't panic. I think that's the main advice. When I've gotten requests, there's a lot of panic. People are like, when can I cancel my medical aid? What should I be doing? I mean, my WhatsApp groups lit up on like Tuesday and Wednesday. It was crazy. Like I was like, I got into trouble at the dinner table for like answering, but it was drama. It was high drama, right? People are worried. I mean, and these are, family and friends, as well as clients, as well as just people that are worried about these kind of things. Let me say this. I mean, this is the signing the bill is the first step in an extraordinarily, I would say it's probably the most complicated legal change we've had in the country since democracy, since '94. I wouldn't put it any smaller than that. It is such a massive, significant potential change. And when I say that, I'm not saying that to scare you more. I'm saying it's going to be so complicated to do right. The number of acts that will have to change, the number of organizational, financial flows that are going to have to change. It is it's extraordinarily massive undertaking. So what that means for now, and probably, if I'm honest, for most of your careers, nothing will change at all. It's going to take that long. And that, let me say, is with smooth sailing. This is before the court cases, of which there will be many. I mean, I know of at least 5 or 6, let me say, material and well-funded court cases that also a conversation that came up in the foyer are probably going to be lodged in different provinces, which means it'll be difficult to bring them together in any kind of joint action. Almost all of those, if not all of them, will see their way through the Constitutional Court on both sides, because the government also isn't going to just lie down if they lose along the way. I mean, I was involved as an expert witness on a Competition Commission court case, which was a comparatively extraordinarily minor issue that went to the court case. It took so long. Every time they called me back, I had to go back for my notes, to an old laptop. It took I don't know, it was over an 8-year period or something. This one case that eventually ended up in the Constitutional Court. So these are much weightier matters, and I think are going to be tied up in the courts for a long time. Question is, what happens in the interim? Well, there's not that much that can happen if the processes are tied up in court. I don't want to get into the politicking of it and the timing of it. Other people can express some opinions there, but I certainly think that it's going to be a long time before anything changes. Let's assume there's smooth sailing. The fund will have to get set up. They're going to have to set up the boards and the accountant. They're going to have to set up all these structures, all these policies. I think that you're years away even from having a fund as a Section 3A entity. So don't panic. I think if you're thinking about your medical scheme cover or your company or your family or whatever, nothing's going to change for a long time. And even when it starts to change, there'll be court cases along the way. Even if those win through in the end, there'll be various other challenges along the way when different portions of the bill start to come into effect. The Section 33s or I can tell you where there'll be a fight is on pricing if they want to procure from the private sector. I've got an investment tip for all of you investment folks, just quickly. I don't know if you know any listed legal firms, but I would put some money there. No, I don't think they are. They're going to do well. Okay, so just a couple of things then, and I wanted to touch on 2 areas. So purchasing is an interesting one because this is what the sort of providers are worried about. The NHI wants to be a monopoly purchaser. It wants to buy all healthcare for all South Africans to the exclusion of all else, which is not done anywhere else in the world. But anyway, that's what the stated intention is. From a hospital point of view, what's interesting there is hospitals are not, I'm going to end way before that so we can have some questions. Hospitals are not well articulated in the bill, actually. When they talk about funding models for hospital care as being global budgets or DRGs, which are a bundled payment. And private hospitals know how to deal with those things, no problem. Much better than public hospitals, actually. But whenever the bill talks about hospitals, it uses very public sector hospital language, district hospitals, regional, provincial, central hospitals. And it doesn't really talk explicitly about how, what the intention is, what the contracting intention is, or the purchasing function, how that will work. Although there's been lots of talk about that in the presentations from the Department of Health powers that be. So the intention seems clear that the NHI is, will for the first time actually allow the government to procure, hopefully at scale, clinical services from the private sector, which is very exciting, except that we don't know at what prices, and we don't know on what terms. And we don't know if it's at the exclusion of being able to get higher prices from private sector payers. So the way pharma works is there's a big cross-subsidy between public and private. The price differences are, anywhere from 40 to 70%. Now, if government becomes the single purchaser of medicines in South Africa, they're not going to be able to do that at current public sector prices because of the massive cross-subsidy. There's going to have to be some kind of averaging out. And so there is going to be that question if there's going to be sort of procurement from private sector service providers. There hasn't been a great track record there. During COVID was probably the closest we came to buying beds and having contracts between the Department of Health and private facilities. And that was really not an easy discussion. I was on the call many late nights with the parties trying to sort of figure out what the costs of those services might be. And it was difficult. There was quite a wide gap there. Similarly, on the recent history, an attempt to contract GPs in to prop up clinical capacity at some public facilities has not gone well. And so there will have to be some kind of, there will have to be some real honesty about what the costs will be and what the prices will be if the intention is to improve access. And I think where more challenges will come is if the tactic becomes, well, we're the only game in town and you don't have a choice. If the pricing becomes predatory from an NHR point of view, then I think again there'll be more legal challenges, and then actually there is a risk that doctors will leave, and that's really what they're worried about, which is why almost certainly SAMA is going to be one of the organisations that place a court challenge. They've already briefed counsel and experts. So they're worried about that. They're worried about not having the freedom to have these different business models. Of course, there's all the accreditation hoops to jump through. So again, this is one of those things where you got to think about the hurdle. I mean, there's certain sort of things that you would want in a bill like this, which are, we want standards and we want good data and we want all these things. So okay, great. To build those things and to capacitate those things is going to take an enormous amount of resources, an enormous amount of time. So again, don't panic. I mean, all healthcare providers, public and private, would need to be accredited, and they need to be accredited by the Office of Health Standards and Compliance, which at the moment has less capacity than this little corner of the room. You've got to go around the country and accredit thousands of facilities. It's impossible. It will have to be capacitated, and it's a long road. Under the right conditions, I want to be bullish about it here, it does open up markets. I mean, you've got, if you can, as a provider, think about, and, when you're thinking about innovation and investing, the idea of being able to provide high volume, low margin healthcare services is going to be the game. It's not, there will be still this leftover game like we have now in a wealthy part of the population, which is for the luxury services and the private rooms and those kind of things. That market will still be there because that's certainly not going to be what the NHR is going to buy. But if you want to be a service provider to NHR, the game will be high volume, low margin. And it's still, altogether 500, 600 billion sector. On the funding side, and I'll spend a little bit more time here. So, I mean, this is really where I think the rubber will hit the road in terms of the NHR's ability to do more than the current public sector. The reality is, the public sector budget, call it 250 billion, and it's only able to do so much with that. I mean, that's about a 4,500 Rand per capita per year spend for public sector. That's not a lot. If you think about how much you spend on coffee across the street in the morning if you work here, just add it up. The public health budget is not that much. They could do with some more money. The question is how much more money and for what services and for what population. Okay. So they talk about, in the Act, they talk about the sources of income that they want. And the first one is public health expenditure. So it's another important thing to realize. We have also sort of focused on the effect on the private sector, but actually NHR is probably a bigger public sector financing reform bill than private sector. Because even if these court cases and maybe the medical aids will win their argument on Section 33, the NHI may still exist, and it may just replace the current public sector funding mechanism. And it's useful when you see some of the presentations to think just about how far that they want to go. The fragmentation they talk about is not only in the private sector and doctors and hospitals being fragmented and multiple schemes. There's also fragmentation on the public sector side. You've got your road accident fund. You've got your workman's compensation fund. They want to appropriate all of those machinery into the NHI fund. And every time I say that, you should be thinking, that's going to add how many years? That's going to add how many years? And probably because all of that machinery is within government control, much more so than private sector, I'd expect that all of those things will happen first before the private sector is really touched in any kind of meaningful way. Now, that just doesn't mean the road accident fund people are going to go, okay, sure, we're tired of this nonsense and getting, lambasted in the press all the time here, just take it. Think about them. I mean, they are these formal Section 3A institutions, and they have their own laws and they have their own structures, and they can't just wind those things up. It's going to take ages to do that. Correctional services, they want to bring in, interestingly, defense, they want to leave out. I suppose there's reasons for that. Then the ones that are sort of more worrying from a taxpayer point of view, from a private sector point of view, are these three: the tax credits, government subsidized medical aid contributions, and then will there be additional taxes? So the tax credit is probably low-hanging fruit. But when I say low-hanging fruit, I mean it's the giraffe low-hanging fruit. It's not like it's not so easy. Okay, I mean it's not a lot of money. You're talking about probably 35 billion. It should be a nice 10% plus 15% top up to current medical public sector budget. But Treasury doesn't just go, okay, sure. You can see what they've done over the last few years. They know there's pressure, so they just don't increase it. Treasury did not play. Let me give an example. I mean, many of you, actually, jeepers. It's to me that's getting old. So some of you are so young. I don't know what's going on, Mark. Like a long time ago, before we had the medical scheme tax credit, there was a medical aid subsidy, which was 2/3 of your medical scheme contribution was tax deductible. So it wasn't this fixed rand amount that we have now. So this was a long time ago. Now, actually, Alex van den Heever reminded us of this at the PHF conference last week. So the problem with the tax subsidy was that it was proportional, which meant that the rich got more of a subsidy, and so they wanted to change it to a flat rand structure, so it was more pro-poor. Once they came up with the policy, did all the maths, made all the policy recommendations, did all of those things, it still took 10 years to move from the 2/3 subsidy to the medical tax credit. Okay, I'm sure you'll all remember how difficult it was to go from 14% to 15% of VAT. Also, not an overnight thing. So now you're talking about removing a tax credit for which there's no Treasury analysis, no formal papers or anything like that, what the effect will be. They don't do this kind of thing without doing that kind of analysis. Our numbers suggest that, look, it's about, call it about 14% of your medical aid contribution, actually. It's fairly meaningful, okay? So if you take that away, it's definitely going to have an affordability knock-on the medical scheme sector. And more so on the lower end, because it's a fixed rand amount, it's the lower income earners that are medical scheme members that would be the most affected. So we think that's going to strain the affordability of lower income earners in the medical scheme sector. And it's hard to say because the elasticity is very hard to predict in medical schemes. It's very sticky, as I showed you all during COVID. People are holding on to that medical cover because they don't really want to go to the private sector, the public sector. But it might have an effect anywhere from 5 to 10% of medical scheme members dropping off, which will be meaningful. It will be a problem. Will they be caught by those health insurance products? Probably, some of them. Well, there'll probably be a shift, a buy-down shift. So people, everybody will buy a little bit less cover. Maybe they'll, buy those network plans that, are where you can only go to select network of providers for a lower premium. And those things are okay. Those are normal market dynamics. But it would still be a systemic shock to the medical system. And Treasury doesn't do those things overnight. So that's the low-hanging fruit, which is very difficult to achieve. Okay. Then government, I'm sort of doing these in order. Then the government subsidized medical aid contributions. That's about another 50, 60 billion rand. Now, this is GEMS. This is Polmed, etc. Now, this is a really tricky one. So firstly, I think it's always irked the Department of Health that GEMS doesn't sit under the Department of Health. GEMS sits under DPSA. I'm not sure if you all know that. So those ministers don't necessarily see eye to eye in terms of, this is an employee benefit. Hard fought, hard negotiated between the unions and their employer. and you know how tightly contested those are. There's no world in which an employee benefit would be taken away without something given back in return. That's not how those bargaining things work. But now the problem you have is, if you're going to, let's say you take the medical aid away, something's going to have to be given back, and the only thing they could give back is cash. But where will that cash come from? Because you need the money to put in the health system. There's no new money here. So again, as a horse trade, there's very little to bargain for there. And the net effect for GEMS members would definitely be we'll give up our GEMS contribution, our GEMS subsidy, which is meaningful. And what do we get back for that? Well, we'll belong to the NHI. Okay, fantastic. But do we get the same access to services than we do at the moment? That switcheroo, that substitutability, and I think that's going to be the key word when it gets tested, is really not obvious. And I mean, we've seen for ourselves that in public, for obvious political reasons, the unions are supportive of NHI. In private, when we're talking about medical aid benefits with them, and we're talking about increases and all of those negotiations, it's not on the table as a negotiating element. And so we're expecting some sharp resistance there. That's to say nothing, by the way, of the resistance that'll come from the provinces when the NHI starts to appropriate the provincial equitable share funds and centralize power at a national level rather than a provincial level. You can expect, especially, again, with the politics, maybe we'll get one, maybe it won't just be Western Cape that has a different political party leading. Maybe KZN will have a different party. Then it's going to be an interesting bun fight. The provinces will not relinquish power and money so easily. And then tax. Let's talk about the tax a little bit. Tax is a really tricky one. So I've got some numbers here, the consolidated government fiscal framework here from National Treasury. So it's useful to think about these things because this is the context in which we're talking about, what is the prospect of raising additional tax for NHI? And I would put it to you that the prospect is zero. There's just no room for that. Now we'll get to what the sort of stated game is, but if you just look at the numbers, we're doing revenue of 1.9 trillion, expenditure of 2.2 trillion. Little googly eyes there. I don't know how your budget works. Mine doesn't work like that. Certainly not for any long period of time. Although when it does, then this happens. You've got your debt service ratios going up. Now, at a macroeconomic level, these are the things we should be worrying about, not NHI per se. But the fact that 16% of at least 16% of every cent on the rand that the government is able to raise going to debt servicing, which is equivalent to what we're spending on social development, which, by the way, is sort of the where all the grants go. That's just how redistributive our tax structure already is. Health is sitting at 14%. That's with the debt servicing. So we spend more on debt than on health. So these are the kind of macro problems that are, who's a modern monetary theory advocate here? Yeah, nobody, because you're in investments. Okay, so we know what happens if you print money. The money printers would say, this is irrelevant. It's domestic expenditure. We can print some money and just spend it locally. It doesn't have any effect. Well, some of us think that it does have an effect. But that still doesn't solve your debt problem, which is international debt. They can't print money to solve that problem. When we look here, where will the money come from? Will it come from VAT? Almost certain it's not going to come from VAT because it's a proportional tax. It disproportionately affects the poor. Will it come from corporate tax? I think there's paranoia there about the scaring off investment. So again, I can't see it coming on corporate tax. There'll probably be some combination of payroll tax and personal income tax. But again, I put to you that these are not substitutable. If they there's no medical scheme world, which is a fantasy, where the whole budget, the whole 500 million, 550 billion is funded by the NHI, and they've managed to raise 200 billion on tax. It's impossible. We've never in our history had such a material change in tax collection. It's not plausible. And again, it's not substitutable. The sort of rhetoric that says, well, we're already spending the money. But I mean, think about how slippery that slope is. We do that in every area of our lives. We do that on food. We do that on housing. We do that on transport. We do that on security. We do that on education. If you have that argument on health, what's to stop the next one being on education? What's to stop the next one being on housing? What's to stop the next one being on food? It's not plausible. There'll always be after-tax money that people are going to be allowed to spend on what they want. I think the last point I want to make on that is, if the government were somehow magically able to raise another 250 billion rand in taxes from somewhere, it is far from a foregone conclusion that it would go to healthcare. There are many competing priorities that they need to fund. I mean, debt servicing being very high on that list. Okay, if they were able to, I mean, if you could wave a magic wand and raise 200 billion rand a year and pay down the debt, that would be fantastic for the country. Or, like I say, invest in job creation, much more so. So when we look at the spending, I mean, health is already 14%. Which is very much in line with what other countries are spending in terms of what government expenditure. We're collecting about 27% of our GDP in tax, which is again in line with what you'd expect for a country like ours. In terms of government spending on healthcare, it's very much in line with what you would expect. So again, if NHI is this all of a sudden magic 500 billion rand fund, it would throw our overall mix of expenditure completely out of whack with international norms, and that's not something that Treasury will do lightly. So again, don't panic. Those kind of extreme scenarios, I think, are highly implausible. Yes, I've said all of that. So, I mean, unfortunately, this is where our effort should be, and it's not, or not enough. If you look at what we're spending on debt servicing and all these other things, what we really should be spending money on is on job creation and GDP growth. If we had achieved even the average GDP growth of our low middle income country compatriots, we'd be over this 30-year period, we're at 2.3 or 2.4, and the average is 4.6. If we had achieved 4.6, just that difference, that 2-point-something difference, over the 30-year period, our economy would be double the size it is now. We'd have double the amount of we already have the extra 200 billion. So again, when you're thinking about this is unfortunately one of those situations where the underlying diagnosis is you're treating the symptoms, not the underlying cause. This is the underlying cause of the fiscal strain that we're under, that we have not managed to grow like our comparator countries for whatever reason. That's a whole discussion on its own in terms of policy. So this is the underlying cause, and unfortunately we're trying to treat it with redistribution. A lot of the sort of the critics of private sector in general, not just healthcare, say, well, we can't have these austerity budgets and we can't improve equality. But that is, that you can't. The reality is the fulcrum that we have, the redistributive fulcrum we have, is not strong enough to use the health sector to improve the inequity in the economy as a whole. It's not big enough. There's not a strong enough lever in the world that you could do that. Just given our degree of inequality, yes, we should have a more equal society. Yes, public health needs more money, and there is some, I think, lower hanging fruit with which that can be achieved. Okay, so I'm actually almost using my time. I'm sorry. But this for me, it's about this. When I talk about health systems and talk macro level, like it's actually about the economy. It's actually about jobs. You can create the kind of jobs we need. You can't run a healthy society where 50% of people are living on 50 rand a day. It's impossible. That's where so much of the attention should be. So I'm not saying health is a sort of a red herring. Obviously, that's our sector. That's very important. We've got to put all of our energy into fixing that and doing the best we can with the resources we have there, both in the public sector, because we could do more with those resources. There's a lot of wastage there, and they need more resources. And on the private sector side, there's a lot of ways to improve. I'm not going to talk about this one too much. It was just some scenarios for what might happen. I want to give you encouragement, though, that the ability of our sector to innovate and to reinvent itself when the time arises, when the pressure point is on, is very impressive. I mean, we interact with many medical aids, third-party administrators, health insurance companies, provider groups, corporate providers, hospital groups, pathology labs, radiology labs, pharma companies, individual doctors and their societies. And yes, everybody's worked up and everybody's agitated and frustrated, but they're working. This is South Africa's story. They're working, they're reinventing, they're looking for technology, they're looking for smarter ways to do things. I won't spend time there. I'm going to end on these points now. So firstly, for the immediate future, nothing's going to change. And I hope I've given you some comfort there. There are second order effects on sentiment to worry about. That's actually a bigger concern. And that's why you're seeing so much of press come out at the moment to say, like, the mood is negative. This is because unfortunately this is happening at a time when trust in government is extremely low. And this is a very high trust institution. It's health, it's a lot of money. I mean, I just beg for what? Show me, show me one success. Give me some parastatals that are doing well, and then, okay, I'll think about it. But we just haven't had that. And so, it's coming at a time when trust is exceptionally low, unfortunately. And that's, people are worried. Like I say, I'm sure you all, if you're in the sector, you would have had a very busy WhatsApp conversations the last few days. Don't be overly concerned, but I think, you've got to keep a watchful eye, obviously, just be responsible. The core challenges are the immediate thing to watch. Who's going to challenge the nature of those? It's going to take a long time. They're going to be well covered in the press, I'm sure, so keep an eye on those. They're going to be serious. They're not going to be frivolous. And as I say, they're going to go to the Constitutional Court. People and systems, health systems, are still going to spend money on staying healthy or getting healthy. That's a universal truth. There's more and more. It's not going away. There's opportunity everywhere for innovation, for improvement. New markets, locally and abroad, for technology. I mean, the technology investment going on in healthcare is incredibly exciting. I mean, I was just listening to a podcast which sort of went through the history of insulin and all